So what I want to do over the next 10 minutes, if this technology works, is to tell you about a UK service, UK survey of the experience of service provision for children and young people with epilepsy. And at this point, I'd particularly like to acknowledge Fiona Williams, who isn't here today, but for her huge contribution, not least to the very complicated statistics that I still don't really understand. So, what I'm going to talk about is to talk about patient-reported experience measures, PREMs, how they interface with the Epilepsy12 audits, and to talk about methodology, what we did and what we found and what that means. And very importantly, as you've just heard, this theme of ease of contact and contactability, that new word, and I hope I'll be able to show you how this data has informed the desire to try and explore that a bit further. So patient-reported experience measures, as you will all know, capture experience of the patient or the carer, their perceived experience in a whole number of different areas. And examples of that might be around information, around interaction with professionals, around accessibility to services. And clearly they can identify areas where we might wish to change and improve our services. And the Picker Institute is a very well-known charity across Europe, and they are experts in these. And interestingly, across the Atlantic, they have CAPS, which is Consumer Assessment of Healthcare Providers and Systems. And interestingly, they provide information to the medical insurance organisations like Medicaid. And Medicaid, for example, use that data to set the remuneration rates to hospitals depending on the feedback from that patient experience. So dare I say it, that might be one thing, perhaps only one that one can learn from the American healthcare system. So this is the fantastic Epilepsy12. It's an astonishing achievement. We to have got the coverage that we have across almost every single paediatric unit in the UK is absolutely wonderful. And as you will know, the three domains in this audit are around a description of the services that are available in any particular unit, those performance indicators that are linked to clinical guidance, and this third domain, patient-reported experience. So what did we do? A colleague of mine who is doing Masters in Public Health for her dissertation did a literature review of all the chronic illness in childhood PREMs that she could come across, and on the back of that we designed this questionnaire. We had a lot of really helpful feedback from Epilepsy Action and Young Epilepsy, and we piloted this questionnaire across families in Scotland. And that questionnaire contained various elements, if you like, hidden within it, but we felt it was important to understand something about proxies of epilepsy severity, because clearly that is likely to have an influence on what one's experience might be as a family or as a young person. And cross-linked that to some of the service descriptor data that I mentioned in the first of those domains. And then to try and gather a series of experience factors on a Likert scale around issues. Did I feel I was listened to? Was I allowed to ask questions? Was it easy to contact the epilepsy service? Something about information. And then finally, a score of the overall satisfaction. We also collected some qualitative data, which I'm not going to talk about this morning, that we're still really looking at. Most of the data comes from the second round of this, and in part we changed the way we did this, and we wanted to try very pragmatically to capture a whole range of different clinic settings. And we asked your audit units to return at least 25 questionnaires from the service across. It might not necessarily be an epilepsy clinic, it might be a general paediatric clinic, it might be a community paediatric clinic. But to ask families about the experience of their care over the preceding 12 months, and to complete those in the clinic and return them anonymously. From that, we have nearly 2,500 questionnaires, 2,500 sets of data. And in response to the question, overall, were you satisfied with the care that you received from the epilepsy service, 88% affirmed that. So what we wanted to do was to try and understand what were the factors that predicted that satisfaction, and to look at those experience factors, how that related to those proxies of epilepsy severity, and how was those related to service issues. And the difficulty with raw counts is that you can't really get a feel for which of those factors are having the greatest influence on overall satisfaction. And multi-level logistic regression is a tool that allows one to do that. And it produces a whole series of things, odds ratios, where a score of 1 has no influence, and a score of over 1 starts to have a positive influence, and a score of under 1 has a negative influence. And we put together a series of regression models, some around the resource availability, some around severity, some around who completed that questionnaire, and then a second regression model, and in fact there were 5 in total, looking at experience factors. So this is our cohort. There is a spectrum of age groups. There is a spectrum of the length of time that child or young person had their epilepsy, and there was a spectrum of seizure frequencies. And there was the numbers of males and females were broadly similar, and roughly half and half. Half of the children had comorbidities, so things like cerebral palsy or intellectual disabilities or ADHD. This is the service data, so you can see that there was a bias towards better resourced units, perhaps unsurprisingly, returning those questionnaires. And particularly, you'll see that applies to epilepsy nurse specialists. So what did we find? So these are the odds ratios, and remember that red line is 1 is neutral, so that unsurprisingly, if you had frequent seizures or if you were on polytherapy, you are less likely to be satisfied. And you can see the whole series of other factors. So if you understood the reason for changes in medication, if you had enough information, if you had guidance about what you were able to do or not able to do, if it was easy to attend the clinic, or if you felt you were seen often enough, those were all positive factors. But counterintuitively, if you had a comorbid disorder associated with your epilepsy, you were more likely to be satisfied. Now, I want you to just take note of the scale on the bottom there, because I'm going to collapse that down in the next slide. And when you add in ease of contact, I found it easy to contact someone in the epilepsy team. There's an odds ratio of 106. Now, whether it's actually 106, the important thing is that it is many magnitudes are greater than any other factor. And that's really what drove this issue about contactability and ease of contact. All this sort of data has it's got significant limitations. We set out to design a pragmatic methodology, really to capture large sample sizes. Of course, we're very likely to be overestimating those satisfaction scores, and we all know that through questionnaire designs. And it's very likely that there's a selection bias towards better resourced units that were more likely to return the questionnaires, but also those larger units may well have a greater spread of different types of clinic settings which don't all have the same sort of resource allocation. So let's come back to this ease of contact. What do we know in other specialties? Well, here's some data about diabetes, which has not been published but is on the college website. And 2 questions here. I can contact a member of the diabetes team between 9 and 5 Monday to Friday. So 90% of people said that was possible. But what about this second question? I can get the advice I need from my hospital 24 hours a day. 80%. I would wager that there is probably very few people in this room who could put their hands up and say that we were able to offer that same level of service for children and young people with epilepsy. So it was really exciting, and I hadn't heard Emma and her colleagues' data before. It was really exciting to hear on that presentation this morning. And we've certainly got a lot of very helpful information, but what does ease of contact about what? How do people want to make that contact? Through what media? Who do they want to contact, and when do they want to contact them? We are in the process of doing a formal validity and reliability exercise on this questionnaire with a view to improving it further, and I'm very keen to try and now match the PREM sampling to the same data that's been captured for the performance indicators. So in conclusion, we think that this is the largest PREM data set for children and young people with epilepsy. We didn't find any others in the literature anywhere near this size. The majority, with caveats, were satisfied with the care provided by that service. And the ease to which a parent or carer could contact the epilepsy service has a more than 10-fold difference to the nearest, strongest predictor of satisfaction. So that PREM data, if you like, provides evidence to support one's intuition, but of course we also found factors that were counterintuitive, and using this sort of modelling allows us to identify the relative importance of factors. And there are, I think, potentially important lessons for service design contained within these data. Thank you very much.